Welcome back to Pediatric. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Al Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
We're excited to be sitting down and discussing calcium channel blocker toxicity, Dr. Merritt Tuttle. Dr. Tuttle, please introduce yourself. Tell us who you are and what you do.
Sure. I'm so excited to be here today. I am originally from North Carolina and did all of my training, so peds residency and pediatric critical care training at Children's Wisconsin. And then I went on to do a medical toxicology fellowship, MCW as well, in the Wisconsin Poison Center. And then last summer, I moved back to North Carolina to Winston-Salem with my family and closer to where I grew up. And I'm currently an assistant professor of pediatrics at Brenner Children's Hospital.
Well, we are so excited to have you here. I love that you did both PICU and Tox. I imagine that this is pretty rare. Can you tell us how you made that choice, how you decided to really dual train?
Yeah, absolutely. So I was originally exposed to toxicology as a medical scribe in an emergency department. And then I kind of had some more tangential exposure when I was really into wilderness medicine in med school. And then had the opportunity during residency to spend some time on an elective rotation at the Wisconsin Poison Center. And that's when med tox really actually started to seem like a realistic career goal. So I had known for a while that I wanted to do pediatric critical care. And during my time at the Poison Center, tox started to seem like something that could be really additive to my career as an intensivist rather than just an extracurricular interest. I got to shout out Dr. Andrew Farkas. He does an incredible acetaminophen and salicylate toxicity talk, and I totally nerded out about that as a resident. And then during fellowship, I started my fellowship at the height of COVID, and we were unfortunately seeing more and more children who were coming in after attempts at self-harm. And I had the opportunity to take care of a child after amlodipine toxicity, an overdose who was ultimately cannulated to ECMO. And that experience really sealed the deal for me that I was going to pursue the second fellowship. And so now some of the things that I think are really excited about the combo training are that, I can look into poison prevention in children with medical complexity and complex medication regimens. I think I'm uniquely positioned to help those folks. And then I'm really interested in ECMO use in poison patients as well.
Oh,
That's
absolutely.
Wonderful and fascinating. Will you tell me what your clinical FT looks like? Are you full-time intensivist plus extra tox, or do you have a split there?
Currently, I'm 100% clinical faculty in the PICU at Brenner, and I truly identify as an intensivist first, and I'm excited to hopefully soon get started with the tox team at Brenner doing consults, and I know Dr. Michael Buehler at the North Carolina Poison Center and would like to do consults with him as well. But, as I'm early in my job here, just trying to establish myself in our unit here and apply the extra pharmacology knowledge that I have. But yes, currently 100% clinical faculty in the unit.
And that makes sense. You sort of establish your PICU practice and then think towards mid-career, how can I cut some of that out as the unit grows otherwise, things like that.
Yeah.
All right. Well, I suspect the answer is no, but do you have any conflicts of interest to disclose related to today's topic?
I do not.
All right. Let me give you a case, and our first question, we'll get going. So we have a 4-year-old previously healthy boy who presents with progressive lethargy over the past hour. The child was playing, unfortunately, unsupervised and was found next to an empty bottle of amlodipine 10 milligram tablets, and with several scattered on the floor. Total number of missing tablets is unknown, and about 30 minutes after the suspected ingestion, this child started vomiting and became increasingly drowsy. On arrival, he's hypotensive and bradycardic. On exam, he opens his eyes to voice, follows simple commands, and there are no focal deficits identified. So we've given you a case with high risk for calcium channel blocker ingestion, specifically amlodipine. As we get into this, will you remind us, for calcium channel blockers, what are the key organ systems affected here? Remind us of the pathophysiology and the importance of calcium homeostasis.
Yeah, absolutely. So beginning with the cardiovascular system, of course, the cardiac pacemaker cells are going to depolarize in response to calcium influx. And so in the myocardium, calcium moves in through L-type voltage-gated calcium channels, and that happens during phase 2 of the cardiac action potential. And that is going to then trigger the phrase we all love, calcium-induced calcium release. And that happens in 2 places. So calcium is stored in the sarcolemma, but it also happens by stimulating the sodium-calcium antiporter. After that, then calcium can bind tropomyosin, so actin and myosin are then free to ultimately cause muscle contraction in the heart. The other really important couple of places that calcium works is in the vascular smooth muscle. So it works similarly as it would in the heart. So through those L-type calcium channels, calcium moves in and allows for smooth muscle contraction in the arteries specifically. And then lastly, and very relevant to calcium channel blocker toxicity, is that calcium functions in the pancreas also through L-type calcium channels to stimulate insulin release. So when glucose is used to make ATP in the pancreas, that ATP then essentially blocks a potassium channel. And when the potassium channel is blocked, you get an electrochemical gradient generated so that calcium can move into the cell and then trigger insulin release. So those are really the 3 big organ systems that I think about calcium being especially important to. And of course, it's also really important in pyruvate dehydrogenase activity, so specifically that in aerobic metabolism.
So you've given us maybe almost like a blueprint to look for various signs and symptoms when we're evaluating a child with calcium channel blocker toxicity. Of course, heart rhythm, vasculature, so looking at arterial tone, and then even issues with the pancreatic function, so hyperglycemia. So we'll talk more about that. We know that there are multiple types of calcium channel blockers. Will you review these for us, broadly speaking, and tell us how their therapeutic and maybe toxic effects might be a little bit different?
Sure. So the 2 big categories we think about are the dihydropyridines and the non-dihydropyridines. The dihydropyridines include amlodipine, nifedipine, isradipine is one I've used a lot, nicardipine also. And they cause predominantly peripheral vasodilation, often with a reflex tachycardia. Important to note here that in severe poisoning, the dihydropyridines can also reduce myocardial contractility and could cause bradycardia too. So you kind of lose that receptor specificity in severe overdose. The non-dihydropyridines are verapamil and diltiazem. I think in pediatric critical care, we probably encounter these less frequently, but certainly kids who get into grandma's purse, for example, are at risk of exposure to these medications. And they work at the SA and AV nodes, and they decrease heart rate and cardiac contractility. Unlike the dihydropyridines, they decrease peripheral arterial tone to a lesser extent.
So you've got the non-dihydropyridines, predominantly bradycardia, and the dihydropyridines, early at least, tachycardia, hypotension.
Right. And I think it's just interesting to point out that the reason these 2 medication classes affect their target organs differently has to do with cellular membrane potential. That's just an interesting fact, but again, want to emphasize that in overdose, loss of class specificity makes it so that either one can show up looking similarly to the other.
Oh, yeah.
So you've piqued my interest. Please tell me more about the cellular membrane potential and why these act differently.
Yeah, sure. So it kind of makes sense. Like you don't want your heart, right, to be able to depolarize at a lower threshold than your peripheral smooth muscle, right? So the resting membrane potential of a cardiac myocyte is about minus 90 millivolts compared to minus 75 in your peripheral vasculature. And so it just so happens that dihydropyridines prefer the less negative membrane potential.
Oh, nice. Wow, that's so
Yeah.
interesting.
Like all the pharmacology that you must learn in toxicology fellowship, it must pay off.
Yeah, got to be honest, the learning curve for Tox was a little steeper than PICU because I didn't have as much of a foundation to build on, but it's wonderfully nerdy and it makes also sometimes for some good trivia knowledge.
Oh, I'm sure. Well, the comments on rounds, right? You have a lot more to say
Oh,
about
for sure.
isradipine than me. Yeah. So let's say you're holding the PICU admission phone, you get a call about an overdose, you hear about, okay, maybe number of tablets, maybe time period. What are those early questions or signs that you're asking the outside hospital about to really say, okay, this is probably a real overdose, or things that might make you concerned?
Sure. In general, I think that we are never totally confident about what a child has taken in a reported overdose. And so I think it's important to not lose your critical care or not lose your basic medical mind just because you're presented with a patient after potential toxic ingestion, right? So, as always, ABCs and know who to ask for help. And so again, as always, if I'm presented with someone who has a low blood pressure with an inappropriately low heart rate, then I'm concerned about severe ingestion. And I want to treat those things and treat the patient in front of me, regardless of what the etiology might be.
So let's say you're working through the ABCs and we've identified bradycardia, we've identified some hypotension. Are there any other specific, perhaps, clinical signs that would point you towards calcium channel blocker toxicity?
Sure. So if the person comes in with evidence of myocardial depression in the setting of reported ingestion, or certainly if there is any kind of high degree AV block, or less specifically, if they have associated, fatigue, lightheadedness, some of those might clue me into calcium channel blocker toxicity. But I think, again, because of the L-type calcium channel blockade in the pancreas, the association of bradycardia and hypotension with hyperglycemia really makes me worried about calcium channel blockers. And there's actually some evidence to say that the degree of hyperglycemia actually correlates with the severity of the toxicity.
I feel like the hyperglycemia stands out quite a bit here. When I think about patients showing up with new onset bradycardia and hypotension in the setting of concern for toxic ingestion, I worry also about beta blocker toxicity. And if I remember correctly, that's associated with hypoglycemia or low sugar. Do you see in clinical practice it being that clean where calcium channel blocker toxicity, those kids reliably present with hyperglycemia, and on the other hand, beta blocker toxicity, they present with hypoglycemia, or is that too simple?
So I would say that you do definitely see hyperglycemia with calcium channel blocker toxicity. The hypoglycemia reportedly associated with beta blocker toxicity is much more for boards testing purposes. So that would be, the safest answer if somebody asked you how glucose might respond to beta blocker toxicity. But actually, Dr. Megan Audette and Dr. Grant Comstock, with whom I worked at the Wisconsin Poison Center, are kind of early on in the process to demonstrate that actually we don't see hypoglycemia very often with beta blocker toxicity. We do see hyperglycemia. So that can be one way to differentiate the non-dihydropyridines from beta blockers, especially because both are going to be associated with low heart rate. A good way to distinguish the dihydropyridines from beta blockers would be that reflex tachycardia that I mentioned before that comes with things like amlodipine most commonly. It's not terribly important that you do distinguish beta blockers from calcium channel blockers because, again, you want to treat the patient in front of you. And so I'm going to give our standard therapies for hypotension and bradycardia, regardless of the etiology. But also specific to these two xenobiotics, the proposed antidote, which we'll talk about in a bit, is ultimately the same, high-dose insulin for both severe beta blocker and severe calcium channel blocker toxicity.
Oh, nice.
One more diagnostic question before we move on. If you're working up a patient for bradycardia and hypotension not otherwise specified, and there is no hyperglycemia, what does that do to your diagnostic interest in like thinking about, is this actually calcium channel blocker toxicity? If there's no hyperglycemia, does this make it very unlikely, or is this another red herring? Like, could this child be like, not eating well plus ingestion?
Totally. It could be that they are not eating well. Have they had prolonged vomiting from some other coincident illness, or did they co-ingest different medication that may cause lower blood glucose or vomiting? So yeah, any of those things. I think hyperglycemia just helps support the diagnosis, but hypoglycemia or normoglycemia definitely doesn't rule it out entirely.
Okay. And then Merritt, before we move on from just the differential, the mystery of tox, what other things, when someone calls you about a kid, unsupervised, bradycardic, hypotensive, what are the must not miss diagnoses? What other things are you sort of working through in your mind?
Sure. So in tox, we call this our low and slow differential. So we mentioned beta blockers and calcium channel blockers. The other two big groups to consider are alpha-2 agonists. So anything that works very similar to dexmedetomidine. I'm thinking clonidine. Kids are on that for ADHD or as a sleep aid. Guanfacine similarly, and then tizanidine, which we see more commonly as a quote muscle relaxant in older folks. So in addition to alpha-2 agonists, the other one you want to keep in mind for low and slow is digoxin toxicity or other cardiac glycosides. So there are some pretty esoteric ones, like we know, of course, foxglove, from which we get digitalis, but then some other plants are lily of the valley, which was all over Wisconsin. Oleander is probably the scarier of these, red squill. And then a quirky one is bufotoxin from bufatoads. So don't go licking any toads anytime soon. And then I might also add organophosphate toxicity, but more commonly in the US, it would be a carbamate pesticide poisoning.
That's incredible. Leave it to the toxicologist to give you a wonderful differential diagnosis.
I know. You guys know so much. That is awesome.
Let's lean to clinical management here. So we have our case. It's a 4-year-old suspected toxic ingestion. So we have that kid on the monitor. So let's say they're magically in your ER or in your ICU where you can lay eyes on this kid. They have IV access. They have fluids going in reflects to the hypotension. We assume you're working through a systematic ABC approach. So for this case, we'll assume that the airway is intact and breathing is intact. Tell us about those first few steps in the hemodynamic management, resuscitation of this child. Maybe even before you're completely sure this is calcium channel blocker toxicity.
Yeah, absolutely. You're starting with fluids. I think as you become more concerned that you're dealing with a toxic ingestion contributing to hypotension, your threshold for transitioning to vasoactives should be much lower for a couple reasons. One, sometimes calcium channel blockers can cause, in severe cases, pulmonary edema and just edema in and of themselves. And then two, if we do have a child who becomes ill enough to warrant insulin therapy, then the volumes of fluid that you have to give with high-dose insulin are really huge. So have a low threshold for starting vasoactives quickly. Ultimately, you're doing all these things kind of all at the same time, right, as we often do for the sickest of children. So I would be giving calcium early in someone who is hypotensive and bradycardic, even if I have no clues yet that this could be a calcium channel blocker overdose. The downside to giving a lot of calcium, there really aren't many. So I would be doing that early. Some folks think about whether or not we should give atropine. And if you have someone with symptomatic bradycardia, you can certainly try it, but it's not going to work in isolation, meaning without the calcium, without the fluids, it's not going to help. And ultimately, it's only going to help transiently. So given that it's inexpensive, it's quickly available, and maybe it'll buy you some time for prepping for the next intervention, then sure, go ahead and give the atropine. But I think calcium early and vasoactives early are probably the most important first kind of steps.
Oh, that's so interesting. I would think that for a dihydropyridine, amlodipine, nifedipine, isradipine, it would be a classic just fill up the tank with as much fluid as you can. But then totally looking back to like my one fuzzy amlodipine ingestion ECMO case during fellowship, she totally had pulmonary edema, right? Like that totally happens. That's so interesting.
Yeah.
You mentioned your systematic resuscitation of these kids, your early vasoactives, calcium, atropine, perhaps. You didn't mention glucagon. I feel like maybe studying for step 1 back in the day, glucagon was part of this regimen. Is there a role for that?
Well, I think first we gotta, why would we even consider glucagon, right? And so, just as a refresher, when glucagon binds to its receptor, it causes an increase in cyclic AMP, and that then leads to intracellular calcium in the myocyte and cardiac contractility. So, that's the whole theory. But effects in animals and human models both are really highly variable. And there are a lot of negative side effects. It's affectionately called pucagon in the tox world. And most hospitals aren't going to have enough to maintain a glucagon drip for very long anyway. And so, we know we have effective alternatives plus these side effects with varying response. And so ultimately, I would not recommend glucagon.
Oh, nice.
All right. So you talked us through this initial resuscitation. I feel like there's lots of discussion early on in these cases about should we do some type of GI decontamination or not. Do you mind just sharing some of the general principles that would lead you in favor of recommending that and really what might be helpful for a child like this?
Sure. So when I'm thinking about GI decontamination, the primary consideration for me is whether or not I'm going to give activated charcoal. And actually, the American Academy of Clinical Toxicology has a whole position paper on single dose activated charcoal. And they acknowledge that there really aren't any well enough designed clinical studies about the benefits of single dose AC to tell you exactly how to use it. And those recommendations are based on volunteer studies. So important to keep in mind that when they say volunteer, they mean healthy folks taking a therapeutic dose of something. And so they ultimately say it shouldn't be given routinely in poison patients. And the classic teaching is that you don't give it after an hour post ingestion. But as you all know, it's very difficult to be sure exactly when ingestion occurred. And I was actually trained to have a very low threshold for giving AC if, and this is a super important caveat, if you have a protected airway. And that's for a number of reasons. One, AC is excreted unchanged, and also so important to know that toxicokinetics are not pharmacokinetics. So you can't expect a drug to move through the body the same way in overdose as it does at therapeutic doses. And that's for reasons like formation of bezoars or saturable metabolism mechanisms. Some medications undergo enterohepatic recirculation. Salicylate is famously one of those. So you might even do multi-dose activated charcoal in those cases. Slowed gut motility, either directly or indirectly. So directly like from opioids or opiates, or indirectly like in the case of calcium channel blockers with super low blood pressure and gut ischemia, or in the case of extended release PrEP medications. All that to say, again, with a protected airway, my threshold for giving activated charcoal is very, very low, and I probably would in this child if he was intubated. Other people bring up gastric lavage or holdout irrigation sometimes. Gastric lavage is essentially never done anymore, in part because it's really hard to find folks who still know how to do it. Most of the people that trained me in tox had never done it, and there are safer alternatives that are at least as effective. So I would only use lavage in a very rare situation. As far as whole bowel irrigation, it should be avoided in somebody who has any concern for gut ischemia. So unless in this patient I could be so sure that the ingestion happened very recently, that there was still some drug that hadn't yet been fully absorbed, I probably wouldn't do it for this child. Other reasons you would avoid whole bowel irrigation are if you have concern for ileus or gut obstruction. And so, I did give it one time to a patient who had ingested verapamil, but it was like an observed kind of in the ED waiting room situation.
Wow.
So otherwise, I think activated charcoal or bust here.
Oh, well, we could absolutely do that. You've intubated the patient, secured the airway. The PICU nurses have descended. NG, not sump. Get the activated charcoal into the patient. Right.
Perfect. Yep.
So as we're planning to take care of these patients, the question about like, is this particular tox that we're interested in, is it dialyzable, comes up in conversation. Is that the case for any of these calcium channel blockers?
So most calcium channel blockers have really high volumes of distribution, and all of them are very highly protein bound. So ultimately, no, dialysis really isn't a good option for these people.
All right. So we've secured the airway, gotten some activated charcoal to the bedside. You are still bradycardic, hypotensive. You're getting your vasoactives in. What are your next steps in the initial resuscitation? What meds are you asking for and why?
Sure. So we've given the IV fluid bolus and we mentioned calcium. I think it's a good time to point out that we're taught calcium chloride, right, can cause phlebitis through a PIV. And so we prefer gluconate usually. But this is a special situation because calcium chloride has 3 times the molar calcium concentration of calcium gluconate. So this is a sort of unique situation where I would actually prefer calcium chloride to calcium gluconate early on so we can just really give a ton of calcium. And ultimately, these children are going to need central access anyway. And you really can't drive your calcium too high. So you often need very high doses of calcium too. So there's no particular iCal goal or anything that I have in mind, just lots of it.
Nice. So you're giving a couple code doses of calcium chloride during the initial resuscitation. You get them lined. You're having your residents order a drip. What type of dosing are you looking at?
I'm truly not even sure what I would start the drip at. Honestly, I don't remember ever having started a drip on these kids. Because I remember talking with the tox folks in the poison center. That was another thing I was very surprised about. They're just constantly bolusing it. They
Right.
don't actually start a drip. Yeah.
Oh,
But you know
interesting.
that if this kid ended up on ECMO in the unit, like they would be on a drip.
Yeah.
And the tox
We did our
folks would be
CI
like,
time. We can do it. Yeah. Yeah.
Will you tell us more about the vasoactive resuscitation here? Is this a case where you're quite interested in choosing epinephrine versus norepinephrine versus other vasoactives, or is it they just need pressors, not otherwise specified?
Well, I think as with any disease state, right, we are trying to figure out what the primary driver of shock is. So if you're dealing with cardiogenic shock, then your first choice might be epinephrine. If you're dealing with primary vasoplegic shock, then you'd likely pull norepinephrine first. And those are the 2 most heavily studied in calcium channel blocker overdose. And so that's what's recommended as first line agents. Some folks would recommend dobutamine for cardiogenic shock, and I think ultimately use whatever you're most familiar with, whatever you're most comfortable managing. That's what's most important because, again, we shouldn't lose our PICU brains just because we're presented with patient after toxic ingestion. So in sum, epi and norepi first, norepi if you find that you're dealing primarily with vasoplegic shock, but truly just use what you're most comfortable with.
Oh, I haven't cared for a non-dihydropyridine calcium channel blocker ingestion. If we're looking at a verapamil or a diltiazem ingestion, would you ever end up on like isoproterenol or something just for the rate?
Sure, you could, but I think similar to atropine, like used in isolation, it's really not going to help you much.
That's fair.
I think it would be a good thing to start with as a bridge again to like accessing your other interventions.
Yeah. Like knock yourself out. Like, yeah.
It seems like an echo might be really helpful in this child's initial resuscitation. Out of curiosity, what does your practice pattern look like there? Is this something that you're doing yourself with a point of care, or is it something that you really plead with the cardiologist to come down and help out with an echo?
A little bit of both. I think it's just so important to do that as quickly as you can to help drive the ultimate therapy, i.e. insulin. It's so important to get it done as early as you can. So yeah, sure, put a probe on the chest to see if you can tell whether or not there's good squeeze. But yes, I would ask also for a formal echo too.
You're titrating vasoactives, you're getting them to the bedside. When we're in, like a typical PICU septic shock situation, 0.2 and 0.2 is pretty high. Can you tell us about the vasoactive requirement that these kids might have and also why?
They will need very, very high doses potentially. And I think it's primarily because the pathophysiology by which calcium channel blocker overdose causes hypotension and bradycardia is just very different than what we see in sepsis, for example. There is actually a study from 2013 by Levine et al. Done with the non-dihydropyridines, and they were looking at use of vasoactives in those patients, which included adult patients. They used maxes of 100 mics per minute of norepi and 150 mics per minute of epinephrine. And so if you say that the average adult man is 70 kilos or whatever, that's 1.4 and 2 mics per kilo per minute, and they had no significant ischemic effects. Yeah, so I think just because the driver of your pathophys is different, it's just so important to keep in mind that they may require super, super high doses, which may also raise your threshold a little bit to cannulate to ECMO, for example, compared to someone with sepsis or some other reason to have vasoplegia or myocardial compromise.
What a good reminder. There's no max dose of pressors, and just match your therapies to your pathology, right?
Yeah, that's awesome.
Yes,
and those
absolutely.
Patients did well, the average of?
They had no significant ischemia. How about that? I can't speak as much to their global outcome, but what you would expect, like necrosis and all sorts of gut ischemia, they really didn't. So yeah, no max dose of pressors. Love that. Sometimes in talks we'll say treat a poison with a poison. And so if folks are asking at the poison center, what's your top dose before you would think about cannulation, we don't give them one. You just keep going up.
Yeah, that's great. Say you're in that precarious scenario where you're ratcheting up these vasoactives quite a bit. You've perhaps even got a calcium drip ongoing, or you've just been repeatedly bolusing calcium, still have a significant bradycardia, still have significant shock. Tell us about your next steps in that scenario.
Sure. So particularly if we have gotten the echo and we see that there is some element of myocardial compromise, then I'm thinking about starting high dose insulin.
Oh yeah. Wait, do you need to see myocardial compromise on the echo to make that risk versus benefit decision about high dose insulin? Or can you say, I'm on 1 and 1 mic per kilo per minute of epi and norepi, the patient's hypotensive, the heart rate is 80. I know that I have myocardial compromise.
Sure. You don't have to have it. There are actually reports of euglycemic insulin therapy being used in polypharmacy overdoses. But it is important to eventually demonstrate myocardial dysfunction because of one of the mechanisms of insulin, which is that it works sort of like milrinone.
Okay.
Yeah. So you could definitely just try it. I know you guys had asked about a test dose. I don't know of any regular practice using a test dose of insulin, but I think getting it started and then trying to demonstrate what your cardiac function is like with a formal echo is totally fine.
Nice. Okay, let's get into the pharmacology. Why on earth would insulin help this, high dose insulin?
Sure. So the actual mechanisms are not completely understood, but there are 3 predominant ones that people talk about most often. And those are, one, that insulin helps the heart use glucose in order to improve contractility. So in our normal physiologic state, the heart uses free fatty acids as the primary energy source. But under stress, the heart switches to using carbs. In calcium channel blocker overdose, we have hypoinsulinemia, right, because of L-type calcium channel blockade in the pancreas. And the hypoinsulinemia results in decreased uptake of glucose by the myocytes. And then you end up with inotropy loss and decreased peripheral resistance. And so by giving exogenous insulin, you reverse that process essentially. The second big mechanism that people talk about is that it is ultimately an inodilator. So it's not a vasopressor. It vasodilates the systemic, coronary, and pulmonary vasculature by endothelial nitric oxide synthase activation. So whereas vasopressors, as we know, increase the blood pressure, they also increase afterload. But insulin can cause myocardial efficiency, improve myocardial efficiency by causing vasodilation, increasing cardiac output, all without increased oxygen demand. So again, very similar to milrinone. And then lastly, insulin helps in calcium signaling. So it reverses the mode of the sodium calcium antiporter, the exchanger. So that maintains intracellular calcium that's required ultimately for muscle contraction. So vasodilation, calcium signaling, and myocardial glucose utilization are the three big reasons that we use high-dose insulin in these cases. And all of those things result in increased inotropy and contractility.
That's fascinating. And if I'm not mistaken, high-dose insulin is also used in beta blocker toxicity management. Correct me if I'm wrong. And if that's the case, would you need a high degree of certainty that you're dealing with calcium channel blocker toxicity to give this medicine? I anticipate probably not.
You're right. High-dose insulin has been well studied and is recommended for severe beta blocker toxicity. And because they present so similarly and because your initial steps in management are going to be to treat the patient in front of you with hypotension, bradycardia, as you would any patient with a similar etiology or a different etiology, yeah, you don't have to be certain to give them a try.
Okay. And then talk to us about dose here. What are we giving?
So when I say high dose, I mean very high dose, and it often makes nurses nervous. But you start with a 1 unit per kilo bolus, and then you continue with 1 unit per kilo per hour, all the way up to potentially 10 units per kilo per hour.
Oh my God, that's wild. The way that I think about insulin is a healthy 70-kilo man, previously healthy, fourth year med student. If that person is naturally making about 40 units per day in their body, you're going to double that per hour for their high dose insulin infusion. That's wild.
Yeah, very, very high. Mm-hmm.
And another way to think of it, your DKA resuscitation, where protocols commonly will start at 0.1 units per kilo per hour. You're starting at 10 times that, and you're maybe even titrating up to 100 times that.
Right.
Wild.
And some things that, I think appropriately so, the nursing colleagues who are helping us do this, right, are really anxious and want to make absolutely sure that no one has made an ordering error. So I think one thing that I talk with them about is that sometimes, not in severe overdoses, but, because these people come in hyperglycemic, sometimes you don't actually have to start supplemental dextrose right away because you have blocked the calcium channels in the pancreas as well.
Wow. Wait, can you tell us about the numbers there? I'm curious if your glucose monitoring is still just like 1 finger stick per hour, like a DKA or septic shock insulin infusion. And then I'm also curious what kind of numbers you need in order to not start high dose dextrose. Is the sugar 600? Is it 250? How are you thinking about this?
Sure. So before I start high dose insulin, I check to make sure that the starting glucose is at least 200. If it's not, then I bolus it. And then I'm checking initially probably every 15 minutes before I feel comfortable after several checks doing it every hour. And at that point, I want to maintain my glucose between 150 and 250.
Okay. And how much dextrose do these kids end up needing usually? Is it uncommon to be on a D10, a D30? What are we looking at?
It's not uncommon to be on a D70 even, which
Wow.
is one of many reasons they'll ultimately need central access. But yeah, we often recommend all the way up to D70 in order that they can get the insulin that's ultimately going to help them.
Wow. My other question is, as someone who's sort of been to the conferences, been in the conversations, we're in the PICU. We're really just trying to perfuse the brain. That's really the end goal.
Heart and kidney sometimes.
Okay. But do a lot of these people have hypoglycemic seizures? This seems like so dangerous.
No, if you are, monitoring them appropriately and protocols vary per poison center and per toxicologist, then you should avoid that. There's actually one study that was done by Cole et al. Sorry, I don't recall the year, but they actually found that hypoglycemia is saturated at 5 units per kilo per hour. So, short answer to your question is no. There is also one report of a patient who inadvertently got 23 units per kilo per hour. And when they tried to titrate down that dose, they couldn't successfully go below 17 units per kilo per hour without seeing some myocardial compromise. So they just left it there. And, obviously wouldn't have if this person had become profoundly hypoglycemic. And then one other wild anecdote is in fellowship before the poison center was involved in a case, we got a call that a person after a calcium channel blocker overdose had been titrated up to 40 units per kilo per hour of insulin. And hypoglycemia was not his primary issue. At that point, it was true. I mean, in addition to his myocardial depression, it was fluid overload.
Wow, that is
Mhm.
that is so wild. And then my last question is, we talked about glucagon, in the setting of calcium channel, and then maybe more pertinently in the setting of beta blocker overdose earlier in this episode. The high dose insulin thing, that's just insulin dextrose, right? There's no glucagon involved there as a med usually.
Correct.
Okay.
Right.
So it seems like some take home points from this particular area is these children have a high degree of insulin resistance. We're not talking about a child who just has excess glucose in their blood. They also have some inability for insulin to work well. So you're going to have higher doses than we would typically see. And it seems like you're titrating your insulin really based off the myocardial function. So this seems like you're doing frequent exams, maybe even frequent echoes, lab monitoring. Will you unpack this further? What are you looking at and how are you titrating this insulin therapy? Say you've given their first bolus and started 1 unit per kilo per hour. Tell us what's your next steps going to look like. How are you going to titrate this therapy?
Yeah, there's no perfect science to say how to do it exactly. I can say that a really wonderful textbook called Critical Care Toxicology that has a euglycemic insulin therapy chapter, and they recommend increasing by 2 units per kilo per hour every 10 minutes. Those dosing recommendations, though, are based off of case reports, which is a lot of tox literature, and animal studies. So it's not associated with any kind of MAP or cardiac output plateau. And so patients might need higher than 10, as I mentioned, for the patient who couldn't get below a dose of 17 without seeing some compromise. So I think ultimately, rather than following just mean arterial blood pressure, you've really got to have consistent, sufficient cardiac output and evidence of good end organ perfusion. So I'm thinking about trending lactates or measured venous oxygen sats, or if you have access to near infrared spectroscopy where you are, all of those things would be good ways to monitor.
Okay, so you've got your patient. Their markers of end organ perfusion are not improving, whether that's like a lactate in the 5 to 15 range, or a NIRS that's dropping, or a MAP that just won't stay above your resuscitation goals. How long are we trying the insulin before we start to think about, okay, what are our next steps?
There's no absolute recommendation on when to do that. And I think what pediatric critical care clinicians might run into is that the threshold for cannulating a child to ECMO is a little bit lower than it is in adults. But certainly folks would be having that conversation about whether or not ECMO is warranted. So there are lots of case reports again and ongoing discussions about which poison people would most likely benefit from ECMO, how do we identify them, timing of cannulation, and a lot of adult clinicians argue that ECMO is not beneficial in primary vasoplegic shock. But I think if you've gotten to the point where you've optimized all of your other recommended therapies and the patient is still very ill, it is reasonable to try to cannulate. And the consensus recommendations published in 2017 about these patients, specifically adult patients, would recommend trying cannulation.
Will you tell us, is there experience in using other therapies, perhaps lipid emulsion or methylene blue or even transcutaneous pacing in these patients? Like if they're refractory to all your other therapies, like prior to cannulation?
Sure. So, regarding pacing, again, kind of like atropine, if a patient presents with unstable bradycardia or high degree block, then it's worth a shot. I would start with transcutaneous pacing, as I think most folks would do anyway, but these patients often have capture problems and it doesn't tend to work in isolation or for very long. And so, with the capture problems, maybe try transcutaneous pacing. If it works, then sure, try transvenous pacing. But in general, it's not typically the best option here. Lipid emulsion therapy, I think it's the one that critical care folks ask about most often. So again, revisiting why would we think about them in the first place? And lipids are theoretically helpful in overdose because they provide a sink or essentially an extra intravascular compartment into which these medications that are lipophilic can be sequestered. Interestingly, also lipids can donate free fatty acids, which we already mentioned is the preferred myocardial substrate. But the most evidence for use of lipids in toxicity is in the case of local anesthetic systemic toxicity. Lipids can make things challenging because it can make it impossible to interpret labs. Some folks have concerns about being able to cannulate to ECMO once you've given lipids, as it maybe would disrupt the circuit. But if you've optimized all your other first-line therapies, your vasoactives, your insulin, and your patient is peri-arrest, or certainly if they have arrested, then it is recommended to try them. I would say that because we've seen inconsistent responses in lipid emulsion therapy in these cases, and because of the potential challenges in giving lipids, I would consider lipids only as a salvage therapy for patients who have arrested or are peri-arrest.
That makes sense. And at our children's hospitals, it's sort of like, well, if you're worried about the circuit and lipids, maybe focus on ECMO in that scenario, right?
Yes, absolutely.
What about methylene blue?
Yeah, methylene blue. There's also not enough evidence to strongly recommend methylene blue, but it actually mechanistically makes sense, especially in the case of amlodipine. So, methylene blue inhibits guanylate cyclase, which is ultimately responsible for cyclic GMP production. And we know that amlodipine actually causes vasodilation among all the calcium channel blockers by stimulation of nitric oxide release, which stimulates cyclic GMP production. Additionally, methylene blue is a nitric oxide scavenger. So, I think if you've optimized all your first-line therapies and you still are not doing well and you can demonstrate a primary vasoplegic shock, then sure, try methylene blue.
Maybe circling back to VA ECMO, reflecting on what's known in pediatrics, is there any way to particularly stratify which kids might best respond to VA ECMO? Like I imagine the child who has profound vasoplegic shock might not do as well because of requirements for flow. And I would also imagine a child who has primarily myocardial dysfunction might improve, but those are just hypotheses. What evidence is there?
There's not a whole lot of evidence. This is actually one of my career goals. Like looking at these poison patients and are there predictors of who would do better than others, and how can we tell when is most appropriate? Because we all know that obviously ECPR is not going to typically be as successful as elective cannulation. So there's really not much evidence, especially in children, for who would most benefit. And hopefully I can work on that.
Oh, yeah. I will say I have to plug here the Coed Children's crew. In one of the ECMO journals, ASAIO, the guy I share an office with, Taylor Nickerson, and our former fellow April Slamowitz just published an ELSO study on this.
Oh, nice.
So shout out Taylor and April.
Kind of moving towards the last few questions of our day's conversation, as we reflect on taking care of patients like this in the past and maybe hearing about other cases, what are some pitfalls or common mistakes that people might find in the management of calcium channel blocker toxicity?
Sure. I think the biggest thing I want to emphasize is going quickly to vasoactives instead of fluids And once you're on high dose insulin, to concentrate your fluids and your drips as much as you can, because these folks almost universally end up with pulmonary edema and significant fluid overload, especially if you're having to use the highest doses of high dose insulin with very high doses of dextrose. Secondly, don't stop the insulin for hypoglycemia if you have ongoing hemodynamic instability. Just continue all the way up to something as wild as D70. And if your PICU isn't an ECMO center, then I would consider early transfer to a place that could offer this for a kid if needed. And I didn't get to mention before, but one of the other things that we worry about with insulin infusion in DKA as well, right, is hypokalemia. My threshold for giving potassium to these patients is much higher. So, I think we're trained in the CICU to kind of reflexively give potassium when you see a potassium lower than 3. But these people are going to have normal total body potassium. It's just driven intracellularly by the insulin. And almost all of them have some level of AKI, and you certainly don't want to have to dialyze all that potassium off later when they start to recover. So generally, I don't give potassium to them unless they have, of course, EKG changes or they're less than about 2.5. And I think maybe you guys will link this, but the expert consensus recommendations for management of calcium channel blocker poisoning in adults was published in Critical Care Medicine in 2017. And they have a great diagram of progression of care and interventions for these patients. And so it'd be a good ready reference to have with you in the ICU. It's easily found on the internet. And as always, call your nearest poison center where there are plenty of lovely people to help you. 1-800-222-1222.
Well, that is awesome. So many good key points here. Dr. Merritt Tuttle, the pediatric intensivist and toxicologist, thank you so much for joining us today.
There's one other. I can't let that go. There's one other. His name is Prashant Joshi. He is an intensivist at Boys Town in Omaha. But yeah, he is the one other. He did Tox first and then PICU, kind of senior in his career, and he's great.
Oh, well, that is awesome. Excuse us.
Yeah, it's like shout out. If you're listening, reach out to us. We'll get you on for another Tox episode, right?
Yeah, let us know. There are a lot of ingestions we need to cover, so this is good.
There you go.
Well, so much fun. Dr. Tuttle, thank you for joining. Anything else to mention for as we close today?
I don't think so. This has been so much fun, and long-time listener, first-time contributor. Thanks for having me.